Well, welcome everybody to the Spirituality Colloquium. My name is Alex Lyon. I am the Associate Director for the Evans Center for Religious and Spiritual Values at IU Health. And we are excited to have two guests with us today to present on their values projects. And I will introduce each of them before their presentation. And so we'll start with Dr. Zeynep Salih. Dr. Salih serves as a neonatologist, an ethicist, and an educator. And she has developed the ethics curriculum for the neonatology fellows. She has a passion in perinatal communication between parents and healthcare teams. She has a study that also investigates how teamwork communication is affected by a structured debriefing intervention. She serves on several hospital committees, including the IU Health's Ethics Committee, the Pediatric Code Committee, and the NICU Research Committee. She is the elective course director for Pediatric Residency Ethics. She's also a faculty member of the Respect Center, and at the national level, she enjoys serving as the co-director for the APA Bioethics SIG. So without further ado, we'll turn it over to you, Dr. Salih, to talk about experiences of parents who received interdisciplinary prenatal counseling for a fetal anomaly in a fetal center setting.
Thank you so much, Alex, for this nice introduction. I would like to start my talk with thanking the Evans Center for inviting me to present our research and also providing generous support to make this research happen. Thank you, guys. So I would like to say that the study I'm going to be presenting today is part of a larger research project. So basically, it involves we started with observations of the care conferences. Then we gave a survey to parents. We did interviews with parents prenatally and postnatally, and we also did interviews with the physicians who do those prenatal counselings with the parents. Of course, the overarching goal is to create programs to help parents. So for today, I'm going to be presenting the survey portion of it. A little bit background, fetal anomalies are diagnosed in 3 to 5% of pregnancies. And with the advanced diagnostic and interventional techniques, the management has become complex that now requires interdisciplinary care teams, both prenatally and postnatally, which resulted in the formation of fetal centers, where single multidisciplinary team provide care for the high-risk patients. Riley Fetal Center was established in 2016. So since March 2020, the center is housed at Riley with 9 different pediatric specialists, in addition to maternal fetal medicine specialists that provide counseling to the parents. The typical fetal center visit day involves advanced imaging of the mother and the fetus, genetic testing and counseling, meeting with the social worker, touring of the intensive care units, both newborn intensive care unit and cardiovascular intensive care unit at Simon Family Tower, and also meeting with the family support group we call NICU Nest. And then typically the day ends with an interdisciplinary care conference. And parents and us, we gather around a long rectangular table. Parents sit on one side, we sit on the other side. Most women are accompanied by their husbands or significant other or a family member. And it usually lasts about 20 minutes to sometimes more than 2 hours. Of course, during this meeting, we share lots of information. We talk about fetuses, the diagnosis, the implications. Specialists share what they expect before and after delivery. We talk about support, and many times we find ourselves talking about decision making for a fetus who has a lethal diagnosis. So we discuss end of life as well. Studies have shown that when the parents receive such information, they go through an acute grief reaction with intense negative emotions. But there is little known about parents' experiences and needs in a fetal center setting, especially after interdisciplinary counseling using video conference. So in this study, we aim to explore parents' experiences and feelings after interdisciplinary pediatric counseling for fetal anomalies at Riley Fetal Center. So we created a web-based survey in RedCap that had questions covering demographics, the care conference, their emotional responses, their religious and spiritual needs preferences, and there were free text questions that parents could write their responses as well. So the inclusion criteria was having a care conference at the fetal center between September 1st, 2020 to September 1st, 2021, more than 18 years of age, English speaking, having an email address, and father of the baby could also take the survey if he chooses. 270 women were eligible, 20 were excluded for being not English speaking, and 1 for not having an email. 249 women received the survey, 45 completed, giving a response rate of 18.1%. The demographic data showed that, again, as we expected, most of the respondents were mothers. A majority of them were less than 35 years of age. Majority of them were college graduates or had some college education. The household income ranged between 30,000 or less to up to 149,000. Again, majority of the participants were white. And most of the parents, again, you can see here that they were either from Indianapolis or the surrounding regions, or South Bend, Fort Wayne, and some were from Bloomington and Gary, most of them. When we asked about parents' feelings about the care conference, most of them found the care conference scheduling met their needs, both the length of the care conference and the timing. And a majority of them, 66.7%, they said they met with some doctors via video call. Then we asked if they liked meeting with the doctors video call. Majority of them, 44.8%, said they could not decide. They neither agreed nor disagreed with that statement. But then a good portion said they liked meeting via Zoom. So then we asked why they didn't like meeting via Zoom. 22% said it felt awkward, followed by it felt impersonal. Then we asked if they found the discussions with this specialist helpful. Again, a majority of them said they found their discussions with the specialists helpful. I was surprised to see that the only specialist that they didn't feel that much comfortable was palliative care, comparing to the other ones and the geneticists. Maybe these were really tough conversations, I guess. That must be the issue. So parents feeling about the care conference. Majority of them said they did not have difficulty asking doctors questions. They understood diagnosis well. They felt the team informed them about the all aspects of baby's care after the birth. And when we asked if they felt they participated in developing a plan of care for their baby, the majority said yes, they did, but still a good portion, close to 38%, they were neutral for that to that statement. Then we asked if they felt comfortable with the delivery plan for their pregnancy. A good portion said they were comfortable, but again, close to 25% could not decide on that. Then we asked their emotional responses after the care conference. The first statement was, after the care conference, I felt less hopeful. So parents disagreed with that. And then they said, although 22% again was neutral, then majority of the parents said they felt more hopeful after the care conference. Again, 25% was neutral. When we put the statement after the care conference, I felt anxious. Again, a good portion said yes. They agreed with that statement, followed by 24% disagreeing with it and 22% being neutral. After the care conference, I felt relieved. 41% was neutral to that statement, when close to 40% agreed with that. After the care conference, I felt sad. So 44% agreed with that statement. 30+% disagreed, and more than 24% was neutral. After the care conference, I felt stressed. Again, a good portion, 50%, is it 50? My math is horrible, but yeah, close to 50% agreed with that statement, and 31% was neutral, and the rest did not agree. Then we asked parents about their spiritual and religious care at the care conference. So first statement was, religious spiritual values are important to me. And a good portion, as you can see here, 50% agreed with that. So more than 50% actually said religious and spiritual values were important to them, when 29% was neutral. Second statement was, I would like the providers to address my religious spiritual needs in this setting. This was surprising to us, because 54% disagreed with that, when 37% was neutral. Third statement was, I would have liked a religious spiritual figure to be present at the care conference. So again, 50+% disagreed with that statement, and 34% was neutral. Then we asked, I would have liked a familiar, someone I know, religious spiritual figure to be present at the care conference. So 50% stayed neutral, and more than 30% disagreed with that. And only as you can see, close like 18 or 19% said they would have liked a familiar spiritual figure to be present at the care conference. We did some associations, and we found that parents participants with more household total income felt less hopeful after the care conference. Participants with higher education levels were more likely to feel sad after the care conference. And participants with more household total income showed higher intention to have a familiar religious spiritual figure present at the care conference. So we did a qualitative analysis of the free text responses. We had 13 free text questions and 29 parents answered that. The themes were asking for more time to process information, asking for more resources and follow-up after the care conference, and guidance in decision-making. So one of the questions was, do you have any suggestions on how to improve the conference room setting? They said if most of the doctors are on Zoom, use a smaller room because the room we use there is pretty large. We already were nervous, so it definitely added to that. Almost felt initially like a job interview. Please share why you like being counseled via Zoom. It was nice because then I didn't have to make an hour drive for something able to do virtually. I was happy that I was able to meet with so many doctors in a short amount of time. In what ways were you comfortable or uncomfortable when speaking to the medical care professionals? It was a very tough conversation to have, but I felt like they were very sympathetic and informative. I wish I had time to process the information given and then ask questions. Everything felt very rushed. Pat listened to, they asked my opinion, but I wanted a little more guidance, input from the team. Tell me things I should consider, long-term prognosis, etc. Those questions. I just wasn't really prepared for what we found out. I didn't know what all to ask, being in a state of shock. About your care conference. I would have liked time alone with my husband to process results before asking questions. I would have preferred a more direct approach in viewing our options. Surgery is an option. Here's what that may look like. Comfort care is an option. Here's what it would look like. We'll support you either way, but our recommendation is XYZ for this reason. We understood our options so very well, but never understood a recommendation. The COVID rules.
We have about 5 minutes and then a few questions.
Sure. The COVID rules make no sense and do not appear to be based on any scientific reasoning. Do you have any suggestions for the Fetal Center? Providing resources for mental health support and counseling. My baby passed away and I was expecting the Fetal Center to call and offer condolences, but no one did. I did receive a call from palliative care, however. Do you have any advice for the future parents? Ask questions. Everyone wants the best for the situation. Give it a chance. I thought there was no hope. You don't know until you hear all your options, so take that chance and talk to them at least. So conclusions. This is the first study exploring parents' experiences after in-person and virtual interdisciplinary care conferences at the Fetal Center using a survey. Most parents find the interdisciplinary care conferences helpful, but a significant portion feel sad, stressed, or anxious after their care conference and asks for resources. Our limitations are low response rate, and we had lack of diversity in participation, mostly white, educated, and all English-speaking parents. Only 2 fathers participated, so a separate survey for fathers might be really helpful. We will receive the survey at different times, especially at the beginning, after the care conference, so this might have affected some answers. Most satisfied and least satisfied women might have been represented disproportionately, like in any other survey study. So next steps, as I said at the beginning, this survey is part of a larger research aiming to explore how prenatal care conferences are perceived by parents and answering their emotional and spiritual needs. So the results of the study will inform efforts and research in that within that goal. So acknowledgements, I would like to thank Indiana University Health Values Fund at Evans Center for making this research happen, and also Life Health Science Internship Program, UR OP programs supporting our interns who worked with us, our wonderful research team, of course. I cannot thank them enough, and of course my fabulous mentor that I'm really so grateful, Anne Cunningham. If she's there today, thank you so much, Anne. Yes, I'm done, Alex. So I'm happy to answer any questions you guys may have.
Thank you, Dr. Salih. I see one question in the chat. Joseph Colquitt is asking, are the recommendations purposefully vague?
Actually, this is a great question. I want to say yes, because many of us, we don't believe that we should give a recommendation to the parents, because this will be paternalistic, and they truly believe it is not our place to make a recommendation. And I don't think we do a good job of asking the parents what their goals and values for their babies either. So yeah. So for your question is, sometimes we make it vague on purpose, but sometimes we really don't want to give either. So I think this will be a mixed answer. Yeah. Great question.
If I could just make a comment, there's some great ethics literature on whether recommendations are a good idea. Dan Sulmacy has written one of these, and some, including him, make the observation and recommendation that recommendations are actually a part of being a good doctor or a good clinician. And I just wonder about asking parents if they want that. Just a thought. We could talk about that for a whole hour, but
yes,
it might be something to think about.
That's really great, and I believe we asked that question in the interview part of the study, because you're right. Like, see, that some parents would not want that, and the way you give this recommendation is very important too, right? I mean, that's a really whole skill, right? How to give a recommendation to a patient. That is a whole skill that I think we all need to get training in. Yeah.
Dr. Salih, there's another question in the chat from Linnell. When the spiritual care question is asked, how would participants know what that means?
This is a wonderful question. So since this was a survey and we were asking lots of things, we didn't want to, we discussed this a really long time. Should we give examples? Should we not give examples, what it means? And we even considered maybe to put like a small notice at the end, you know, what it means. But then we, in the end, we wanted to leave it to the person, whatever he thinks what religious, spiritual need or presence might be. Yeah.
Great. Another question in the chat. It was said that not having a spiritual figure present was important for some. What drives this desire? Not having a spiritual figure present was important for some.
I mean, my interpretation is that I think parents want to separate this fetal care conference totally separate from having a chaplaincy figure there. I think they want the meeting to be or they see the meeting as a business meeting, that they will come and talk with the doctors and get the information and decide what to do with that. And the second thing is, I think they so much rely on the person that they come to the conference as the support person, you know, their husband, their maybe father of the baby or the sister. And it may be that maybe they really need someone they know, someone that they know them, because during the interviews they talk about this quite a bit. They say my support people are from my church. They say that. So I wonder if we say, hey, you can bring a support person from your church. I wonder if they would have been okay with this. We just said, actually, we asked this question in another way, and they did not say no. They were just neutral. I think we could get more answers to your question if we could ask them directly in person.
I wonder too if sometimes having the chaplain or even a religious figure from outside is a reminder of one's own mortality or of the mortality of one's child, and that maybe that barrier comes up because of how often we only have been calling chaplains at the end of life, and so and that sort of actually goes along with what Alexi's saying, I think, here in the chat regarding having spiritual support from the system. I think many patients and families don't understand what chaplains do, and maybe neutral, negative for that reason.
Yeah, I think that makes great sense, because this is such a really vague question too, right? Religious person could be very religious, very spiritual. Actually, we had a patient, like a parent I knew from the care conference. They were very religious people. But then when I went to the bedside after baby was born, I said, would you have liked a chaplain to be there? This was a young mother too, and she said no. So I think I agree with you, Alex, that maybe they really think this is more like that situation, versus now we are here in the care conference to see what we can medically and surgically do for this baby, yeah. And maybe, as Lex is saying, they really don't know what the chaplain can provide.
That's right. We have more work to do to
yes,
to teach our patients and our colleagues.
Mm-hmm.
Well, thank you very much, Dr. Salih. We're going to move now into our time for Dr. Areeba Kara to present. And Dr. Areeba Kara was born and raised in Karachi, Pakistan, where she attended medical school at the Aga Khan University. She completed her internal medicine residency here at IU and has been a hospitalist at IU Health Methodist since 2003. She is very focused in her research on diversity and equity, also in hospital-based care, quality and safety, teamwork and education. She serves on the department's DEI committee and serves in national committees for the Society of Hospital Medicine dedicated to furthering DEI. She's the assistant editor for the Joint Commission Journal on Quality and Patient Safety. She is a mentor directing the PACES program in the Division of General Internal Medicine and Geriatrics. And she is here to speak on her project, the Experience of Underrepresented Minority and International Medical Graduates Working in Hospital Medicine. Welcome, Dr. Kara.
Thank you so much for that introduction. You made me sound super important. So thanks for having me. All right. So acknowledgements, well, thank you for funding this work and everybody who has helped along the way. But thank you especially to people like you who care about issues like this, because that's the only reason why it's worthwhile continuing to study it and trying to make things better. Shout out to the team. I think I saw some of them on the Zoom thing, but now I can't see them. Monica Huffman is our research coordinator from Reagan Street. Dr. Janine Z. Cheng is a pediatrician and an intensivist. That's me, and then Anne Cottingham, by the way, who speaks of this group all the time and tells me you guys are cool people. So I'm glad I'm getting to meet you. Going backwards. I have no conflicts of interest related to cash, but I would acknowledge that I, like everybody else, probably have my unconscious biases. And so if I say something that sounds like, where is this coming from? I apologize, but I have them too. Before we dive in too much further, we are talking about the experiences of those who are underrepresented in medicine and who are immigrants. So if this is your lived experience and this is not the day that you have the capacity to hear some of the ugly, please don't stay. But please do think about that. So, okay. Our agenda today, we'll just, talk about what our work is, and we will review some of the preliminary findings. And I really do hope we have some time for some feedback. I will emphasize again, the findings are preliminary. We are maybe halfway done through our coding, but wanted to share what we have. So starting out with the story of why am I doing this work? Why is this important to me? And many years ago, before I had kids, I would volunteer to work every Christmas because, I didn't celebrate and I didn't have kids who wanted gifts. And I was rounding on Christmas Day, and there was an older lady who was just not medically ready to be discharged. And I said to her, I'm really sorry you're here on Christmas Day. And that was like flipping the switch in her. And she snapped at me. She's like, your kind doesn't know anything about Christmas. So why would you say that to me? And that was, in the movies, there's a pivotal moment, and it's been more of a journey for me, but I always remember that time because I don't think I have invoked anyone's spirituality in an encounter since that exchange. Fast forward 10 years, and my son was 6 years old, going to summer camp happily, until one day he comes back and says, I don't want to go. And I'm like, well, after much probing and prodding, turned out there was a child who came up to him and said, your kind is the kind that winds up in jail, so I'm not going to play with you. And so these are stories that I just want to say that this is deeply personal for me. I am in it to make it better for my kids and make it better for our patients. But globally, why is this important for us to understand in the medicine community? Well, 1 out of every 4 licensed physicians is an international medical graduate. And while we have about 13% of our population represented by African Americans, we know only 3.5% are represented as full-time faculty in our US medical colleges. And these numbers actually look even worse as we ascend the ladder of career advancement, and we try to look at chairs and full professors and so on. International medical graduates do report poor job satisfactions, and faculty who belong to underrepresented groups in medicine have reported a lower sense of feeling included wherever they are. So others, there's been a good bit of research done in this area, and what we already know is that between half to 3/4, so up to 75% of those who are underrepresented in medicine have faced discrimination during their careers. Others have described what these experiences might be like, mostly for learners and trainees. Similarly, for hospitalists, some studies have described how interactions may not go so well. And they've often done it with this focus of career advancement, like how does this prevent you from growing, from assistant professor to associate professor to full professor. And there's some emerging literature about how this can impact your empathy and your burnout, and then in turn, how can that affect outcomes? So what we don't really know is, what is the day-to-day life like for hospitalists, and like what is this milieu of discrimination and bias feel like, and what are the support systems that might be in place, what should be in place, do these interactions impact patient care, what are the long-term effects, and what about those who are out there observing discrimination, what impact does this have on them? So I'll pause a second to say, do we know what a hospitalist even is? It's a relatively new specialist. I am one, and they're generally internal medicine or family medicine trained clinicians who solely work in the inpatient setting. And just imagine the inpatient setting and just think of these doctors only ever working there. So no clinics, no established relationship with patients, and essentially hospitalists cover all sorts of patients all through the hospital. So our scope as we started was to really describe discrimination and bias, which would be based on immigrant status, race, and ethnicity. And our goal really is to make things better without absolving ourselves from the responsibility of educating ourselves, because this has been a work in progress for myself and the whole team. So to describe the setting a little bit, our scope was all the IU Health facilities. We started at Methodist, University Hospital, North and West hospitals, and included everybody who was in the hospitalist service line, including administrators, advanced practice providers, and physicians. What we did, we described the study in group meetings, followed up by email, hallway conversations, and said, hey, come and just interview with us. The participant would schedule an interview time, and because we came into COVID during the study, all our interviews were conducted over Zoom Health. They were audio recorded, and then we, the team, would listen to the recording, read the transcript, and then get to coding. So the questions we asked them, we started off with, hey, what's the general vibe of your workplace? How are things going? Tell us a little bit about any event in which you felt discriminated against. How has the pandemic impacted things? How do you think this has changed you over time? And then we added a question of, tell us about a time that you yourself felt that you were acting in a biased way. So diving into the findings, recall that the first question we asked was about, what is your general workplace like, and how does it feel? And participants described this sense of what felt like a safe interaction, what was a potentially unsafe interaction, and these vague spaces that could fall in between, right? So stuff that generally felt safe were, your immediate colleagues. The smaller groups felt more cohesive. If they were close to each other, they felt better. The overall morale of the day impacted how interactions went. And, if they had a more diverse population, they felt things went better. Where they started to feel somewhat unsafe were interacting with those outside hospital medicine, so our consultants, people worried about how their own reputation, their own experience, and kind of the stress of their day, and how sick the patients were. The worse that got, the more scary and weird and negative the interactions had the potential to veer towards. And, life is not ever this clean, right? It's not going to be in concentric circles. And there were many, many instances of blurred boundaries. And we had one participant describe a story where a very close coworker had on her computer desktop a picture of, and I apologize, of Barack Obama with a noose around his neck. And this was obviously a very unsafe feeling for this person. So while we would hope that our closest spheres are always the safest, this isn't always true. So some of the quotes, just to kind of, presented in the words of our participants, when they started to describe the physical separation, somebody said, well, with COVID, we've been using our own cubicles to stay distant, and that's really not been very ideal or very fun. Talking about, hospitalists versus specialists. Well, my other hospitalists, they're very helpful. And then the rest of that sentence was, but the others are not that easy for me to interact with. This person was really talking about how the nature of their day and the stress of their day kind of intersects with how the day and the interactions go. Getting bogged down with having to answer multiple calls or to be at the bedside for several times, or people are getting sick or just getting a lot of new business. That was described as a not very good day. And then, depending on where in the pandemic we caught our participants, we heard, at least at the start, we heard some positives coming out from that. And people said, well, we almost feel a little bit hopeful. I felt like there's more of a we're all in this together type of feeling. People seem like we've had the much larger thing to concentrate on now. There were others, other mediators of, how people thought their interactions in the day went. And, we don't really stop being humans. So, there was one participant who was like, well, it could be multiple things in my brain. Like I may not have been in the right state of mind in this pandemic stress and with kids and other responsibilities. And this was just kind of describing conversations. And here's another one. But in the emergency room, the ICUs, and the inpatient hospital wards, where people are more ill and more desperate and with less resources and just under more duress, I would think this stuff becomes more in your face. And just generally speaking, I think the more stress that you're under, the less reserve people have in terms of being able to feel empathetic and sympathetic, because everybody's just working harder and has less energy, less reserve, less emotional reserve. So essentially this idea of, you've just got nothing left in the tank, and maybe the worst of you is going to come out instead of the best of you. Diving into asking about exactly some examples of, discrimination they may have experienced. We got two extremes of responses. One was, yep, it happens all the time. And then the other was, nope, it doesn't happen at all. And these were some actual instances. One participant talked about, well, I got in the room, I introduced myself, and the patient was like, nope, I don't want to deal with a Muslim doctor. This participant was describing a specialist who was acting irritated and just kind of, I think she's describing feeling somewhat bulldozed in this interaction. And then this one was like, well, I walk in and they'll just be on the phone with a family member. They'll be like, oh, the nurse is here, I got to go. And I guess it's just kind of, because I'm female and young. More, a common one is mistaking me for another Asian doctor. That happens regularly. Usually it's a patient who says, oh, don't I know you already? I saw you with Dr. So-and-so in their office. Another more blatant one was a physician being told, God, aren't there any white doctors anymore? This participant just recalled an experience in residency. She said, well, I was at a small hospital and the immigrant physicians would not be picked for most of the things. So it was not a fair competition or a fair chance. We wouldn't even know how the opportunities would be given or selected. And in describing this event, somebody else commented on, well, I think there are just two different sets of rules for two different types of people. So then we try to dig into, well, when you're confronted by something like this, do you even respond? And if you do or don't, how do you decide? And these are some of the things that kind of popped up. Like, if you have support, where you were in the hierarchy of things, trying to prioritize patient care, trying to decide, is today the day I even have any reserve to handle this? Trying to balance your responsibility to your patients, your learners, and the other multidisciplinary team. Trying to sort out why did the patient or why did this person even say this, and sort of the extreme or what did the comment actually entail. So in real time, somebody is trying to process all these things before they decide that they're even going to do anything about this or not. And so these are, yep.
About 5 more minutes.
Gotcha. Okay. And so these are just some of the quotes that speak to that. And so here was one who said, I drafted an email, but then I thought, I'm just not going to respond because I didn't want them to further peg me as the angry Black woman. So what are the aftershocks? Like, what happens to people if they have been experiencing these kinds of things repeatedly? And, we noted there is this, you kind of take your authenticity out of it. You don't want to laugh too loud. You don't want to seem too passionate because you might be aggressive. Even take it down an octave because you don't want to seem like you were yelling at them. I can't lie, it's a burden that's exhausting. There's a lot of self-doubt that comes from this. We know that this is extremely prolonged. People were describing events that happened from decades ago. And there is this phenomena that we've been calling decoding, because again, people just cannot understand what is happening, can't even figure out if this is discrimination. And then there is this whole realm of people who are taking very personal responsibility to try and change, because they feel that if they could be different, things would be different. So this is really trying, again, there's a big question mark, but this is how we are thinking about it. It appears that there's something in our work environment and our relationships that might mediate the occurrence of discrimination. We talked about the stress of the whole system, the fact that we don't have relationships with the patients are very sick and there's just a lot of demands. Then there's this whole bucket of what mediates that we even recognize that discrimination is happening. And I put a huge question mark on personality and self-assurance because it sounds like I'm blaming the victim here, but many participants themselves describe, oh, I think it just rolls off of me. So I'm putting it there because I heard our participants talk about it. Then we have this bucket of what actually mediates the response, and then what mediates the long-term effect of what happens to you. And one of the things I do want to talk about was, it seems like the basis of why you are being othered makes a difference, because many young females talked about how as they became more experienced, they became more confident. However, many Black clinicians talked about how they became less confident, had more self-doubt, because there was nothing they could do about their Blackness. But you could do something about your lack of knowledge and your expected growth as a clinician. And this idea of personal growth comes up over and over again. And physicians almost describe this tension between choosing to be a human with normal responses and emotions and being a physician in that moment. So we've had challenges. The pandemic was not easy for anybody or us. So anybody who participated was a rock star. We did do all of our interviews remotely. Not sure how much it helped or hurt. The team itself, we had our own emotions to deal with, and we would hear about these things. And if we have time, what I would love to hear about is this challenge that we came up with to even to define exactly what discrimination is, because we would hear stories from people who would preface their comments with, oh, I don't think this was discrimination, and they would launch into a story which was somewhat horrific, and others who would describe things that, by my sort of framework would be trivial. And so I know we shift towards the impact of an act when we talk about microaggressions. But we even check the literature. I just don't know. We are getting such a wide variety of responses and experiences. who is the arbiter of saying, well, this act was discrimination, but this was not? And that's what I had. And I will stop talking. Made it in time. Okay. Thank you.
Thank you, Dr. Kara. Two powerful presentations back to back. What questions are there for Dr. Kara, or even comments?
Or help me answer my question. Yeah.
So Kara, that was great presentation. Thank you. So in your study, did anyone come up with a suggestion to make things better for them?
Yes, we have a specific set of questions asking about, well, what would help you? And those are almost the easier parts of, understanding what they're saying. But, people want a sense of community. People want, there is no clear pathway of responding to this event. But part of the problem is we spend so much time decoding the event, like, what did I just experience, that it's difficult. But yes, there were many, many great suggestions about, hey, we need a specific person to go to, we need specific policies, and we are getting all that together. Thank you.
Dr. Kara, thank you.
Areeba is good.
Can you hear me, Dr. Kara? Okay.
Yep.
Thank you for the presentation. This is similar to the work that I have a passion for. DE&I always is important to me, and justice. And so just thank you. I'm curious because you said this is preliminary. So I'm interested in, I heard you say policies and defining discrimination. What other areas do you see the research taking you towards as you do your research?
Yeah, I think, so this obviously is a research effort involving, 50 minutes of qualitative interviews with people. And I hope that we can find or create a very quick survey of what is what is the climate really like? Like, it's harder than we think it is to measure the instances of these events. Like, what is the prevalence of this kind of behavior, right? And so I think describing this, as Dr. Salih pointed out, I think creating strategies to help based on what we're hearing, that should be step one. And then figuring out an easier way to get a finger on the pulse of what's really happening out there would be important. And then another one that I am really passionate about is this idea of what is it in the nature of work in the hospital, or what's gone wrong that has made this place of healing and a place where, our science and our spirituality should intersect. What made us go in this direction?
So you see my hand going up. You're actually touching into some spaces and places. I just had the same conversation with a professor from Christian Theological Seminary. And so offline, I would be interested in connecting with you as you continue this work and this dialogue. So I hope that's okay.
I would love that, because this has really been a journey, and I some days leave more confused, or most days leave more confused. So I would love that. So I see. What about ways to reorient the patient population with a healthier center versus a center undergirded by racism? Do an education component for patients upon entry, is that possible? This is really, really tough, because so many of them are having the worst day of their lives. And we walk in and we have no relationship with them. And forget about all the package, all the backpack of stuff that we are carrying on our bags, just going into that interaction. I would love it if our patients showed up on their best behavior, and there have been attempts to have a set of patient expectations, and what would we do if a patient says, I don't want to have a Black nurse, I don't want a Muslim doctor. But I also see that it's just, I don't know, that's a really hard one. If somebody else has a more articulate response than me, I'd love to hear it.
So, Clara, I have a question about it too, right? He said, I'm wondering about the cost and benefits to doing research.
Oh, how is it hearing others' stories? It's, I think it's emotional, it's thought-provoking, and it really lights a fire, and hey, we can do better, and there's no reason we can't do better. So all in all, I am optimistic because this is a conversation we were not having 5 years ago. And so in some ways, I'm feeling more empowered.
Yeah.
I don't know, Jill, I don't know if that was your question.
Yes, it was. Let me turn my camera on. Yeah, I'm wondering what it's like for you to, personally to be experiencing these events, and then also hearing about other people's, and what it's like for you.
Yeah, it is not fun. And we anticipated this. So actually the team, before we interviewed anybody else, we interviewed each other, made each other answer these questions to try and box out the emotion we knew we would feel. So we don't code alone. We always pair up to code these transcripts and watch.
Oh, good.
So that's been helpful.
Good.
So it's almost painful to say that it's 3 o'clock. Maybe I can say, we want to thank everyone for coming. If you have to leave, feel free to do so. But if there are a few minutes left for questions, Dr. Salih, Dr. Kara, we can stand a little bit longer. Before we do have the official convening, I wanted to thank both of you, and just excellent work. And I think about this question we asked in pediatric oncology around a family who had been actually kicked out of the hospital for passion, you might say, emotion, and we were able to bring them back. And we said, what if families left the hospital healthier societally than when they first entered? Maybe it's not just about the cancer or the physical illness. I also want to just say also that November 22nd is our next spirituality colloquium. I'll be presenting with Anastasia Holman, and if our colleagues are available, Robin Axel Adams and Mona Ryad, to talk about the religion and spirituality in medicine scholarly concentration in the IU School of Medicine. So those are my blurbs, and I guess this opens our unofficial time.
Lexi, are you able to unmute and say what you?
Oh yeah, I put a comment in, having both witnessed and been the subject of really prejudicial comments over the years, that I used to think that we ought to just put up with it. And I attended some of the Department of Medicine training that Silk Soto gave about being an upstander, and talked about times where a resident experienced prejudice and attending stood up for them in a way that was both, I think, kind, compassionate, and firm. And I have changed my feeling. And I see what you're saying about people being at the worst day of their lives. And I will say that I've made mistakes myself when I've been stressed to the max. But that doesn't mean it was okay to let it slide. And I don't think it's okay to let it slide for patients. So I've changed my attitude over the years. I just want to say that, but it hasn't, it's taken a lot of time and a lot of thought. And I realize it's complicated.
No, I totally appreciate that. And I think there are these grades, right? Because, I had a patient stand up and threaten me and say, well, I thought in your culture, your husbands had beaten you to submission already. And that was, that was kind of a no-brainer. Like, yeah, I'm going to call security. But then it's these weird digs in between that get that are exhausting, and we don't even know sometimes what to call them. Yeah, still working.
So, Kara, I have a question. So I think I wonder if the participants brought up discrimination or bias or some other way that they didn't feel included by their colleagues,
Yes.
not the patient. Because for me, if this come from patient, to me, I mean, it doesn't bother me that much, to be honest. But if it comes from a colleague or someone that I work with in the NICU, then it really, really hurts,
Yeah, we did hear a little bit about that, and some of it was, we have advanced practice providers in our practice, and so some of them felt that their physician colleagues perhaps were discriminating against them, or not feeling included in that way. We thankfully had relatively few, but not zero, instances of racist sort of interactions between colleagues. But this is where I was like, where do I sort of say, okay, this is discrimination and this is not, but just we heard some. How do I get invited to the rest of these?
Gloria can add you.
I would like that very
on
much.
here. That would be, you'd be welcome to that.
I will certainly add you.
Yeah, and anyone else, send your email to Gloria Robertson if you want to be added to our colloquium listserv.
Yes, please. Please do.
Well, if anybody has ideas of how we can do better or help me do better, please reach out.
Thank you for your excellent work.
Thank you, Dr. Salih. It was so great to meet everybody.